for you tonight, and we are finally on a new streaming service, which should be amazing. Lots of added upgrades and lots of benefits. So we are super excited to have you all on board. We're looking forward to answering all your questions as usual. And we're just going to give everybody our traditional few minutes to log on, and then we'll have you all on board. So thank you to Restream.io, who is the streaming service we're now using to reach out to all the different platforms. And hopefully it'll be glitch-free tonight for you guys. We got sick of the other one crashing, so we decided to switch. And don't forget to ask your questions. We are totally on board with being able to answer all of those. So I'll let everybody get all sorted out. Grab your tea or coffee or juice or water or whatever you're having. And we'll get the show started momentarily when everybody signs on. In the meantime, I will tell you all, if you're doing any exercise or weightlifting, do not try doing deadlifts with 225 pounds. That was a very bad idea. I have barely been able to walk for the last 2 days, and it's been agonizingly painful. So for all those of you out there with back pain issues, I totally get it now. And hopefully I'll recover soon and manage to muddle my way through all of this. Thank you to all of you who signed up for our petition. We have our media release ready very shortly. We're going to go to the press and then use that to hopefully spur the petition past the 10,000 mark. If we can get past 10,000, I think we've got a really strong case. So we need about another 2,400 signatures. Whatever you guys can do to help, that would be amazing. And hopefully we can get everything ready to go. Okay, and I see some questions coming on already. Some good questions coming up. One from Jessica on Facebook. That's awesome. I would definitely address all of these questions as we go through. So feel free, by the way, to ask your questions at any point in time. We do go back to the beginning, just as kind of like a fairness thing. We do first come, first serve for the questions. So if you have questions, put them up at any point in time, and we will be happy to go through everything with you and address the questions as we go. How's everything running over there? Good?
Butter smooth, man.
Butter smooth. Tarek is in a good mood because I fed him sushi tonight. So hopefully everything runs smoothly as anticipated. Okay. I think we've got quite a few people joining on, maybe just a few more seconds, and we'll be ready to go. For everyone that's wondering, just a little bit of an update on where things stand. The province is slowly opening. Unfortunately, Windsor has not fully opened yet. We're working on that, but we are waiting for the College of Physicians and Surgeons of Ontario to address exactly when we can get the IVF unit up and running. We are ready for embryo transfers, and the team is in the process of getting your embryo transfers organized. So don't call in with a flurry of phone calls or anything like that. They are processing everybody's requests. They will reach out to you as soon as they have answers for you. We are trying to get to everybody as quickly as possible. And Sarah and Mara and Fariba and the whole team here have done a great job of getting all of that put together. It is a huge task. So we appreciate your patience while we get that running, but we are good to do embryo transfers once embryos are here. For the patients who need egg retrievals, we're still doing them in Toronto at Create. We've already done one and it worked out brilliantly, so we're really pleased with that, and we'll continue to do so as time goes on until the college allows us to get the program started here. Hello from Brazil. Wow. Hello from Brazil. That's awesome. Well, guys, we reached Brazil. That's like got to be a milestone for us. You got to write that down somewhere today. Hello back from Brazil. That's amazing. Thank you for joining us. Okay. So I'm going to get started. So a lot of people ask me, and we always kind of try and find our topics for fertility fact or fiction based on sort of what I learn about during the week or what people are asking me about during the week. So a lot of people ask me and say, can we have sex around the time of insemination, or can we have sex around the time of IVF? And so the question was, what's the evidence for that? Is there a risk? Is there a benefit? Should we say yes? Should we say no? And traditionally, I've always said it doesn't really matter. And you can do whatever you want to do. If the mood strikes, go for it. But we also tell people to kind of take it easy right after the transfer, because you literally don't want to rock the boat too much. So if you're going to have sex, just make it gentle. But otherwise, it doesn't seem to be harmful in any way. But there are some centers that actually tell their patients to avoid having intercourse. And so I thought I'd look it up and figure out what is the right thing for all of us to do. Should we avoid intercourse when you're approaching the fertile zone in terms of doing an insemination or doing IVF, embryo transfers, or is it okay to go ahead and do it? So towards that goal, we have this little gem of an article from Human Reproduction Update, and it is a little bit older now. It's 2015. There's an update in Fertility and Sterility from 2016, essentially the same kind of idea, and they both kind of share many of the same studies, but this one's a little bit more thorough in terms of being an actual analysis of the data. So what they did was they went through kind of the theoretical part of this, and I do want to explore that with you, because what we hear from our end is, I'm trying to get my partner to save up so that he doesn't use up all of his sperm, so there's lots there when we go to have the insemination or the IVF. And the answer to that is, that's definitely not a good idea. We know for sure that if you wait too long, a lot of the sperm die, many of them become abnormal, and the percentage of DNA fragmentation actually increases. There are actually good studies that show that the sperm quality is better if you ejaculate even twice within a 3-hour time frame, so that you may want to actually not use the very first sample that's produced, but rather use the second sample produced just 3 hours after the first one. So the concept of saving up is definitely not a good one. You actually want to try and ejaculate more frequently, not too often. I definitely don't need you guys doing it every 3 hours. Your wives will undoubtedly leave you, or your partners will. But you want to do it at least every 2 to 3 days to keep the sperm production fresh. The other part of it was, is there something about not just the sperm, but the seminal plasma or the seminal fluid, which is the ejaculate, that actually can benefit patients trying to get pregnant? And there actually appears to be. So when you look at in vitro studies where they're studying cell cultures and either rodent models or even human models, they have shown a significant amount of change in the inflammatory properties of your immune system when it's exposed to seminal fluid. So I'll read you a couple of quotes. It says, the delivery of male seminal fluid at coitus, which is intercourse, induces an inflammation-like response, activating immune changes in both humans and rodents. Obviously, none of us care about rodents, but in humans, it's really important. So one study from 2012 examined the human cervix with a biopsy following unprotected vaginal intercourse while you used a condom, and then no condom and no intercourse at all, just nothing. So they demonstrated that the seminal plasma, the ejaculate, introduced at intercourse actually elicited pro-inflammatory cytokines. So these are little chemicals that float around inside you, and they increase the inflammation or the inflammatory changes in you, and chemokines, basically the same thing. They attract immune cells, and a robust recruitment of macrophages, dendritic cells, and memory T cells. So these are all components of your immune system, which are needed in order to actually help an embryo implant. Too much of them, they don't do well, but just enough of them and it actually improves your chances. So the leukocyte and cytokine environment induced in the cervix by seminal fluid appears competent to initiate adaptations in the female immune response that promote fertility. So again, that seminal fluid can actually improve your chances of success rather than decrease them. And by improving your chances of success, maybe there is something to frequent intercourse or intercourse around the time of insemination or IVF that may be actually important for you. So that was kind of the theory behind the study. And they said, let's have a look at this. So these authors actually went through a huge database, multiple databases using Medline and Embase, a couple of other ones that are smaller. And they created one of these famous meta-analyses that hopefully you're all familiar with now because we've discussed them here many times before. For those that aren't familiar, a meta-analysis is when you take lots of little studies, you pool the data together and you get the one bigger study. So after a whole bunch of screening procedures, excluding articles that they didn't like because they weren't meeting the criteria for being strictly sort of scientific, they ended up with 7 articles in total. And the interesting thing with these trials was that all 7 were randomized controlled trials. So half the group, without knowing that they were going into that group, went into the study where they were exposed to the seminal plasma, and half the group got exposed to just saline or just a catheter, but it definitely wasn't the seminal plasma going in there. And some were with intercourse, some without. So I'll kind of go through that because that part's sort of important for you. So I kind of want to tell you what they did in these 7 studies because that's important. So one study in 2009, 390 patients total, they had sexual intercourse at least once 12 hours after they did the embryo transfer. And the control group was just no intercourse at all. The next study was in 1986, so a much older study. They had 152 patients, and they actually did insemination of untreated semen. So this is just your ejaculate, a very small amount up to a maximum of 6 milliliters, which is a huge amount, anywhere from 36 to 48 hours prior to the embryo transfer. The next study, 2013, 385 patients, half of a mil of prepared seminal plasma, so that's just the plasma from the ejaculate without all the sperm, 1 to 2 centimeters into your cervical canal. Your cervix is usually about 3 to 4 centimeters, sometimes even longer. And the rest of it was deposited in the vagina after the egg retrieval. Another study, 2013, half a mil injected into the vaginal vault just after the egg retrieval. In 2,600 patients in center 1, and then in a second center, center 2, they did another 400 patients. So center 1 did sexual intercourse on at least one occasion within 2 days prior to and 2 days after the embryo transfer. Center 2 was sexual intercourse on at least 2 occasions, once within 12 hours prior to the egg retrieval and once within 12 hours of the embryo transfer. And then 2009, 168 people, kind of like earlier, they did an injection of the seminal plasma 2 to 3 centimeters into the cervix, the rest in the vagina. And lastly, that same author, 2013, did 279 patients, and they did 1.5 mils of diluted seminal plasma injected just above the end of the cervix. All of these people used either no treatment in the control group, or they injected saline so that people didn't realize they weren't getting the seminal plasma, which is what's called a blinded trial, because then the people getting the treatment don't know if they're actually getting the treatment or they're getting just saline. So there's no bias in the sense of a placebo effect. So the data from this is kind of interesting. When you look at the individual studies for each of these, they actually did not show significance except for one study which was kind of borderline, and another study which actually showed a benefit. So the study from 1986, which is going back a long way, so the data is a little bit different. 1986, the IVF success rates weren't as good as they are now. And we didn't have all of the same protocols and treatments we do now. That showed a benefit for sure. And then one of the 2013 studies showed a benefit as well. The other ones actually did not show a benefit, and they definitely weren't detrimental. But when these authors pooled all of the studies together and they looked at it within the intention to treat analysis, so that means you were analyzed in the group you were assigned to because that's the group you were assigned to, they actually did demonstrate a significant increase. There's a 23% increase in the clinical pregnancy rate, which is huge. I mean, I think that's a really significant number and important for everyone to recognize how significant that is. And when they analyzed it in terms of the cycle protocol, so that's actually what happened to the patient rather than which group they were assigned to, it was basically the same, a tiny bit bigger. It was 24% instead of 23%. So this is a fairly robust number. Now, interestingly, when they actually broke it down into real numbers, they actually showed that there was not a huge difference in the actual number. So they went from about 25% out to around 29%, which is not a huge jump in success. You're going only 4% up, but 4% is almost that, sort of 23, 24% number that they're working out there. So that's where this data is coming from. So you can't expect it to make a huge difference, but it does appear to make at least enough of a difference to tell people you don't have to hold back from having sex. So there are some other advantages to this. As I mentioned, prior to, there's no question that you're going to improve the quality of the sperm in terms of the number and the motility and the progression of the sperm, which is how fast they're swimming. So all that's really important. Number two, it does look like it helps with the female immune system in terms of setting it up to be ready for implantation. Number three, it's good stress relief, and we know that stress can actually increase your failure rates. So if you're less stressed, there's more intimacy, more comfort. It can be really helpful. And then the last part of this that's really critical to remember is how much of a burden the psychological and the psychiatric aspects of fertility are when you're going through fertility treatment. There is no question that our patients have a huge emotional, psychological burden. That's a big part of the reason here at VRC why we've set up probably one of the most comprehensive programs available anywhere. And we tout that all the time. We say to everybody, no one walks alone at VRC. That's kind of our catchphrase to make sure everybody understands we're paying attention to not just the medicine, but the emotional, the psychological, the spiritual, the moral burden that some of the things we do can carry. And if you can reduce that through intimacy, make yourself feel more comfortable, make the partner feel more comfortable, that is huge. It's really, really critical for you. It'll make you feel better. It'll make you feel better as a couple. And when the stress and the tension are down, the success rates actually legitimately increase. So there are numerous benefits to sex before, during, and after your IUI or IVF. All of these studies focused on IVF, but the IUI studies are essentially the same. And hopefully someone will come out with one really big study looking at this to do sort of a proper randomized controlled trial. But it certainly doesn't look harmful, and it does look like there are multiple benefits. So the answer to everybody's question about whether or not they can have sex before, during, after, the answer is go ahead and have sex definitely for IUI, because your implantation of your embryos is days later after the actual insemination. So that's not a problem at all. For IVF, before is probably reasonable, and you can have sex after. I'd probably recommend you avoid it immediately after, just because we don't want to jostle the embryo right after it's being placed there. But prior to embryo implantation, it should be fine. And probably sometime after 12, 18, 24 hours, it's again going to be fine. Just no swinging from the chandelier, right? You need to take it kind of easy. This is the wrong time to experiment with 50 Shades of Grey. You kind of want to have more gentle, loving intercourse rather than sort of going at it hard. So is it a fact that you can, or fiction, that you can have intercourse around the time of your assisted reproductive technology? It is a fact. It not only is safe to do so, it likely will improve your success rates. So make sure that you like, subscribe, and comment. We want to make sure that we get as much feedback from you guys as possible. If you have concerns or questions about this, don't hesitate, let us know. And we are always happy to go online and take the questions and do what we can with them to help make your journey a better journey for you. So that's it for that part of the show. We're going to go to questions now. And are you going to ask from your end, or do you want me to? Okay. So Tara's going to ask us some questions. Fire away.
Okay, here we go. Okay.
Jasmine tea, by the way, green tea, very good as an anti-inflammatory. I promote green tea.
Does endo contribute to SIBO? SIBO?
Does endo contribute to SIBO? I have no idea what SIBO is. You'll have to spell that one out for me.
Okay. Well, I did.
I meant the patient. Can the patient spell out SIBO for me? Yeah.
All right. What is happening with embryo shipment? I've been getting the runaround. What's going on?
So in terms of embryo shipment, I addressed that at the beginning. As I said, no one's giving anybody the runaround. We have just been waiting for all the pieces to be in place. We are reaching out to everybody. It's a one-by-one process. We need our partners on the other end who are shipping embryos to ship them, and they're only willing to do one at a time. So we are doing it as quickly as we possibly can. There is no need to call in or phone in. We are reaching out to everyone one by one. If you haven't heard, it's not because we've forgotten you. It's just that we are getting to everybody as quickly as we possibly can. There's obviously a lot of people, and the problem is we only have so many we can do per week because they're only willing to ship so many from the other end. So we're working on it diligently. We have your best interests at heart, and we will be in touch with you. Don't call us on that one. I promise you we will reach out to everybody that has sent in their form, and we're getting that done as quickly as we possibly can. You should be getting updates on a regular basis, just saying where we're at. When it's your turn, you'll need to do some blood work. We'll need to get the shipping documents prepared for you, and then we'll get them here.
You always talk about how great Zymo is. Are there any negatives?
No, the only problem with Zymo that we are aware of is if your sperm motility is very low, they may not be able to get through to the other side. So when the motility is very low, it's not the right technique. So we don't use it for the guys that have very, very poor motility.
In your 2-week wait, can you still get deep tissue back massages?
Oh yeah, somebody asked me about that. Deep tissue massages can probably cause some inflammation that's not good. So I wouldn't do anything too strenuous during your 2-week wait. A gentle massage is probably fine, but anything that's like grinding into you where it's making you sore or uncomfortable is probably not a great idea. I'd avoid that. Let me take one from here. Since the Zymo IUI filters out 90% of abnormal sperm, it's not abnormal, it's 90% of the sperm with high DNA fragmentation. Wouldn't it make sense to not have sex during that cycle so you don't risk exposing your egg to unfiltered abnormal sperm? Dealing with male factor infertility. So that's a great question, but the answer is it doesn't filter out 90% of the abnormal sperm. It actually filters out the sperm with high DNA fragmentation. It does filter out some of the abnormal sperm as well. But the main function is that it gets rid of the weaker sperm and it gets rid of the sperm with high DNA fragmentation. So no, in fact, having more frequent sex further helps eliminate your DNA fragmentation and produce better sperm. So definitely do not save up. You should be regularly having intercourse every 2 to 3 days throughout your entire cycle. Make sure that you're doing that on a regular basis. And then around the time of ovulation, even every day is okay. If you're doing insemination, still probably every other day. Buttery smooth video, you commented. That's hilarious. I'm wondering why the office switched from blood pregnancy test 2 weeks after IUI to now at-home tests. Also, shout out to Lisa today. Loved my experience with her during my IUI today. She's the best. Oh, thank you. Okay, so first of all, Lisa is amazing. We love Lisa. All of our nurses, Carrie, Tara, Grace is on mat leave now, Sarah here in Windsor, and my dear, dear friends at Nahal prior to my departure, Massa and Mina, amazing nurses, one and all. I love you guys. You've all been amazing. Diane is still off, and Diane we've loved for years as well. So thank you to all our nurses. You've all been amazing and great help to our program throughout the years. So as far as the home test, we are still doing a blood test, but we wanted everybody to start with the home test. And that way you don't have to wait to come in for your blood test, but we will confirm with a blood test as well. So we're actually doing both. We're doing the home test and then the preg test with blood to confirm. Do you do satellite monitoring at your office if you are doing IVF outside of Windsor? I think what you mean is, oh, yes. Yeah, we do. Totally. So we do monitor here as a satellite for doing our cycles elsewhere. And we actually do satellite monitoring for other institutions as well. Everywhere from Europe has done satellite monitoring with us. We've done satellite monitoring for multiple places in Toronto, Ottawa, and a number of times now for US institutions as well. I'll do one more here. Hi, Dr. Victory. I have a question about light periods. Mine has always been on the lighter side, about 2 to 3 days with a medium to light flow. I was wondering if that could be a sign of poor uterine lining. If so, what can someone do to thicken their lining to make it better for implantation? Thanks. So yeah, thin lining can represent that. It doesn't necessarily mean that, but it can. Very easy to figure out. You need an ultrasound maybe between day 10 to 14 of your cycle. It'll show us how thick your lining is getting. And the magic number is 8 millimeters. You want your lining to be at least 8 millimeters thick and have a triple layer pattern. So that's really critical for everybody. As far as what you can do to help it, so we've talked about this before. Vitamin C, D, and E have been shown to be beneficial. Viagra can help. Aspirin can help. There is some experience with using certain chemicals and agents, so GM-CSF can do it, and there is possibly some evidence that using platelet-rich plasma can do it as well. We're going to try that in one patient very shortly. So I haven't used it before, but my understanding is there are some people that are doing it, and there is some evidence scientifically that it does work. So there are some things you can try. There's also multiple different types of estrogen. So you can take oral estrogen, vaginal estrogen, transdermal estrogens. All of those are known to increase the thickness of your lining, and that's definitely your first go-to as far as things that you can do to improve the lining thickness. Fire away.
One question, endosurgeries. Any news on endosurgeries?
Sorry, say that again?
Any news on endosurgeries?
Oh, on endosurgeries. I'm sorry. So endosurgeries are basically on hold. Right now, we are waiting for the hospital to allow us to do cases. And they are very slowly allowing cases to resume, but the cases are mainly cancer cases and urgency cases. And as you can well appreciate, having waited 3 or 4 months, there are a number of people with urgency cases and emergency cases and then cancer cases, all of whom need to be addressed first. So we don't actually have dates on surgery. What I am telling everybody is, unfortunately, do not hold your breath. It is going to be a very, very long wait before surgery. Sorry. Oh, okay. I got a bunch here. Let me go back to the beginning. Oh my God, that's a long list of questions. Okay, so here we go. For a 30-year-old with good AMH, anti-Müllerian hormone, and other results, how many PGS normal embryos would you expect? Oh, great question. Okay, so first of all, if you're 30 years old and you have normal AMH, don't do PGS. It'll reduce your chances. It has been proven to be useless. It does not help you in any way. And no matter what they tell you, don't do it. It's a waste of time. It's a waste of money. It is not beneficial, will not assist you. You lose 50% of your usable embryos doing PGT at that age. So I do not recommend it. Having said that, how many would I expect? I love the crystal ball questions. They're impossible to answer. So I can give you a percentage. It depends on how many eggs you make. So if you're 30, you have normal AMH, we would anticipate you would make anywhere from 10 to 15 eggs normally. Probably about 80 to 90% of those should fertilize, and about 60% should become blastocysts. So somewhere between 5 to, let's say, 8. And then from that, you would expect about 30 to 35% of them to be genetically not normal. So about 65, 70% should be okay. So you may end up with somewhere around, I guess, quickly doing the math in my head, 4 to maybe, I don't know, 4 to 6 embryos at the end of it all that should be genetically normal. Now, that's just numbers, and it can be very variable, but that would be a reasonable expectation. Any thoughts on the Receptiva test? I don't use Receptiva. We are currently experimenting with a different one, which I'll get into probably in another show. We did use ERA before. It was useless. I don't recommend it. We have a fertility factor fiction on that. It's only useful in patients who have very, very thin non-triple layer endometrium. Even then, I'm not sure it's useful, but it is not useful as a general rule. So stay tuned for more information on Receptiva and another one that we're playing with. I'll let you know once I've had more experience with it. Recommendations for 40 plus with 2 C-sections and wanting another baby. Lots of vitamins, lots of sex, and have another baby. No reason why being over 40 would stop you. It is more difficult. So take your vitamins, make sure you're taking folic acid, make sure you're taking your vitamin D, coenzyme Q10, that's helpful as well. Healthy diet, lots of exercise, keep your weight under control, sex every 2 to 3 days, no bad substances, so no smoking, no drinking, no alcohol. You want to definitely make sure that you're taking all the correct steps to keep yourself in the healthy habits. Okay, back to this side. Question about Menopur. Does this injection help make more eggs or larger eggs? That process is tied into one another. So when we help you make more, it also makes them grow. And so the growth process ends up with your eggs becoming larger because that's the natural process of the egg. But Menopur is designed to increase the number of eggs you produce. And it's actually particularly good at improving the quality of the eggs that you produce as well. So we love Menopur. It's a fantastic product. We use it in almost every patient, but we also use another product actually from a different company because we like to mix and match a little bit. And that way you get maximum number and maximum quality, which has worked really well for us throughout the time that we've done it. Why does this one say show? I don't know. That's weird. Okay. Is there an FET protocol, natural modified, natural medicated, that is preferred with a history of severe preeclampsia? Oh, fantastic question. So with severe preeclampsia, you need to be on aspirin. There is some evidence that you should have a non-medicated cycle, in other words, a natural cycle, because high levels of estrogen can be associated with increased risks of preeclampsia, which is why frozen embryo transfers are actually better than fresh, because in a fresh embryo transfer, your estrogen levels are really high from your IVF cycle, whereas in a frozen embryo transfer, they're a lot more reasonable. But in a natural cycle, it would definitely be best. So that's probably the best way to go, but definitely lots of aspirin. That is critical for patients with a history of preeclampsia. I think I missed a question there. Hey, doctor, our process with you is on pause because my husband's health card expired, so he can't get any testing done, and because of virus, he can't get a new one right now either. Is there any way I can get my separate test results back while we wait for him? Oh yeah, sure. You can just call and say you want an appointment for just your test results, and he can do his stuff through Service Ontario without it being open. You could also always just go to another city where there is a opening now for Service Ontario, because I think they're back in action. We wouldn't necessarily want to do fertility treatment yet, because if I don't know what his side of things shows, I may be exposing you to treatments that are not beneficial. That can be costly and actually be detrimental in some cases as well. So I wouldn't necessarily do treatment for you, but I'm happy to share the results with you. That's not a problem. Okay. Is it too late to freeze your eggs if you already have low ovarian reserve? That's a great question. So the answer is it's probably not a great idea. Egg freezing actually requires a high number of eggs, even when you're young, in order to succeed. So there's a study from the group called Iui in where was it in Spain? I think it was actually Barcelona. And they demonstrated that you needed 15 eggs frozen to achieve one pregnancy for a woman under the age of 35. I've seen other numbers saying at least 6 or 7, but there's no question you need a lot of frozen eggs to achieve one pregnancy. And if you're dealing with low ovarian reserve and age is becoming a factor, you need even more. So you need to come and talk to us. We need to see how many eggs there are, what your AMH value is. It's certainly possible you'll need more than one try, and we're happy to do that, but it does become more complicated, and we certainly prefer to freeze embryos rather than eggs if your AMH is going down, or even better, just get you pregnant. Yeah.
I'm going.
Okay.
We're waiting on an appointment consultation with you for cycle monitoring. While we wait, what are some vitamins or supplements you can recommend? 1 miscarriage, 2 years trying to conceive. Thanks.
So vitamins, any antioxidants are beneficial. Lots of vitamin D, minimum 2,000 units a day. You should get your vitamin D levels checked. It does have a significant impact on your fertility and miscarriage rates. So both getting pregnant and staying pregnant. Coenzyme Q10 is helpful. If you have PCOS, we use NAC and acetylcysteine. We also use inositol, which is a great product as well. So those are the basics in terms of vitamins and supplements. You need a good prenatal. You need your folic acid, your iron. There's probably some benefits to using the fish oils as well, so we do recommend those also. And then there's a host of other supplements you can try, but those are the main ones that will be beneficial to you. I've got one here that's quite interesting. It says, does poor speech quality contribute to higher aneuploidy in embryos? I think they mean sperm quality, not speech quality. I have no idea if poor speech quality contributes to higher aneuploidy in embryos, but poor sperm quality probably does. In particular, if there's DNA fragmentation, that might be the case. We don't know for sure. To the best of my knowledge, that study doesn't exist. But it makes sense that if the sperm quality is poor, the risk of aneuploidy would be higher. Having said that, aneuploidy, generally speaking, is more related to the age of the egg rather than the quality of the sperm. So that has more of an impact than the sperm does. Here's one. I know stress can impact infertility. Is it a good idea to start anti-anxiety medications prior to starting IVF? My GP has offered to prescribe meds, but I'm concerned. Thank you for that excellent question. So we do know that anti-anxiety medications, especially the SSRIs, can have a negative impact on fetal development in terms of often heart and lung issues. So if you can avoid them, you should. If you can't avoid them, you can't avoid them. And if you need them for your mental health, then by all means, take them. And we will work around it and do our best for you. But if you don't need them, then avoid them. So things like melatonin, which will help you sleep better, are important. Your relationship with your partner is super important. Meditation can help people. Prayer, if you're religious, can help. Exercise helps a lot. Talking about it with someone, cognitive behavioral therapy can help. So there's a lot of techniques you can use that don't necessarily require that you go through the whole process of having to take medication. So there are options for you without needing to use meds. And if you can't get along without the meds, then yes, by all means, use them. How many IUIs are suggested or allowed before moving to IVF? And how does a couple applies to be chosen for IVF funding? Okay, so we normally do 3 of any specific technique of insemination. So for example, 3 with pills and then 3 more with shots. And if that's not working, occasionally we'll do 1 or 2 more. But generally speaking, if it hasn't worked after 3, we switch. And we move on to the next step. So you might go from pills to shots, or pills to pills and shots together, and then on to shots. And then if you failed 3 cycles of shots and insemination, traditionally we'll offer to move on to IVF. For the funding, if you are in any of 4 specific categories that we selected, we put you directly in. For everybody else, we actually ask them to try insemination 3 times, and then we put them on our funding list, which we are currently working on getting. So again, go to our change.org petition, sign up on the petition so we can get funding to help you. Because once they give us funding, we won't have a problem for our Windsor patients anymore. Let me see if I can take one more here. I'm trying IUI this month, inshallah. Inshallah, I hope it works. Small intestinal bacterial overgrowth. Oh, that's what SIBO was.
Oh,
So what was the original part of that?
I'll tell you.
Does...
Endo affects semen.
Oh, wow. Great question. No idea. Jen Strong, if you're on, tell me if endometriosis affects small intestinal bacterial overgrowth. I will look that up, and maybe I'll get Jennifer Strong, our amazing naturopath, to answer that. She is back. So if you're with us or you want to reach out to Dr. Strong, just reach out to Dr. Strong. She can answer that for you. I've never seen anything about that. Having said that, endometriosis is associated with inappropriate inflammation. Inappropriate activation of the immune system often has negative effects on normal bacterial flora in a detrimental way. So I would anticipate it probably affects it negatively, but I've never seen a study on that for sure. Let's take a Facebook question. So sex 2 days before sperm sample is okay before egg retrieval? Yes. Clinic is stating no sex 2 to 5 days prior sperm collection. Thank you. Yeah, so I mean, 2 days is fine. Within 2 days, it even appears to be fine. So I don't think that it's a problem, but definitely you want to do what your clinic is telling you to do because they have their own experience. But I go with the science and I do what the science says. So I'm never hell-bent on one protocol or procedure. I believe we should do whatever the science shows us we should do with the measure of experience to help temper that. Okay, I was a little confused earlier this week. I was told I had a 30 millimeter on my right side during an ultrasound, that you don't use anything over 25 usually for procedures. I am on Letrozole. I did end up having my IUI using that egg, but I'm just curious why you don't usually use ones over 25 and why mine was used. If another one doesn't grow, we're kind of forced to use the larger egg, but traditionally if we have one big egg, we'll actually wait and see if other ones grow, and it depends on whether we think that that egg is a cyst or an egg, and it can be hard to differentiate sometimes. So that might be what happened in your particular cycle. Hi, Dr. Vic. Oh, what just happened? Sometimes it blanks it out. We got to figure out this. Okay, I lost someone's question there. Sorry. How many IUI procedures do you suggest before trying another approach? So we just answered that one. My husband and I will enjoy your advice and have tons of sex. Yes, that's great. I'm glad to hear that. That's what it's all about. If doing a natural FUT protocol without estrogen, is there a clinical reason to stop breastfeeding if the child is over 1 year old? Definitely. So breastfeeding increases your prolactin, which drives down your estrogen level and does thin out your lining. You will not have the same success rate, number one. And number two, there is absolutely no benefit to breastfeeding a child after the age of 1. It's for maternal comfort. It is not for the child. There is no study anywhere that demonstrates that children have any benefit to breastfeeding past a year. So you need to stop breastfeeding if you're going to try doing a embryo transfer, for sure. With a frozen donor egg cycle, it is typical to begin the cycle with birth control pills, and if so, what is the benefit? In a frozen donor egg cycle, you don't need to start with birth control pills, but it will help normalize all of your hormones so that they can get your lining right. Make sure you're not going to produce an egg at the wrong time, because if you grow an egg and it releases prior to the time where they're ready to put in the embryo, the timing is screwed up, and then they'll have to freeze your newly made embryos from frozen eggs. So it'll be frozen egg, thaw, embryo creation, refreeze, rethaw, then do the transfer, which we like to try and avoid. Will an RE ever prescribe Clomid without doing the ultrasounds? I live in the States, and it's not covered by my insurance. We never do ultrasounds for Clomid unless something's wrong. So you absolutely should be able to get Clomid without doing the ultrasounds. So that should not be a problem for anybody. There is no benefit actually. And that was that last week or the week before That was 2 weeks ago we did that one. Yeah. So 2 weeks ago, Fact or Fiction was on that exact topic. You do not need ultrasounds or monitoring if you're just using Clomid. It's of no benefit to you whatsoever. So tell your RE that the data shows that there's no benefit. And if they're arguing with you, you can get the studies and show them it's not difficult. Is it too late to freeze your eggs? Oh, we answered that one. Okay. Here we go. How does the practice of intermittent fasting impact fertility? I've been doing it for a few months and I've lost a good amount of weight, but wondering if that's negatively impacted my fertility. It shouldn't. There are some studies just coming out now, because it's just now where intermittent fasting is becoming really popular, that are suggesting it actually may be beneficial. So as long as you're not going overboard with it, and you're not doing it like every 2 days or something, it's like a once a week kind of practice, it's probably fine. And that if you're losing weight, we know that that is beneficial for fertility. So I think that that's a good thing, not a bad thing. Anava Infertility is watching us. Hello, our friends at Anava. If you have low ovarian reserve at 36, but AMH of 7.5, so not good, but not horrible. That's actually reasonable. So if your ovarian reserve, if your AMH is 7.51 picomoles, that's on the lower side, but it's not that low. You still have a very reasonable chance and lots of options. So nothing wrong with trying that. Can similar results be expected with progesterone gel over progesterone injection shots? No. So there is good data that shows that the progesterone in oil shots for IVF are better than doing just the gel. There are multiple studies that have shown non-inferiority, but there's also a couple of studies that show that the injection is actually better. So we do recommend you use the injections with the vaginal progesterone. I do love the vaginal gel. Crinone is a great product. We've had loads of success. So when our patients have coverage, we definitely recommend that. Okay, I'm finding this pandemic to be stressful as I'm a healthcare worker. Trying to get pregnant, Dr. Strong is awesome. Thank you. And Dr. Strong is awesome. I love Dr. Strong. As of now, do you have to go to Toronto for the entire IVF procedure? Yeah, so I need you in Toronto to do your egg retrieval and then to do the embryo transfer, although we can always make them in Toronto and then ship them here for the embryo transfer. That's not a problem. Hi, Dr. Victory. I'm a little consider in April. I think you mean concern. In April, I had a miscarriage. In May, I got my regular period. Now in June, it's been almost a month without getting my period. I did take a pregnancy test here at home, but came out negative. This is the first time this happened to me. Just have a worry. No, I wouldn't be worried about that. Right after a pregnancy, your periods can be quite irregular. So it's important to get your hormones checked and make sure everything's okay. But that shouldn't be a problem, missing just one period. I'm not worried about that at all. To follow up on my previous question, if my cycles are irregular, sometimes ovulating on day 6, sometimes on day 31, should I be on a birth control protocol on a frozen donor egg cycle to avoid the refreezing of the embryos? Yes. So as I said, if your cycles are crazy irregular like that, you have to be, because you could be growing an egg and releasing it at the wrong time. You'll end up with what's called endometrial asynchrony, where your lining of your uterus has been exposed to progesterone for more time than it should have been, and you've now literally received birth control unintentionally through a natural process. So you need the lining of your uterus to have the right amount of exposure to progesterone in order for the embryo to implant. If it's being overexposed or underexposed, it won't work. So it's really critical in a case like yours to be on the pill. That would be very, very helpful, for sure. Did we get enough signatures for the petition to bring funding to Windsor? We're working on about 2,400 more, so not quite yet. But I think we have a very strong case, and Tarek is working on that from Ibrahim Strategies Group. So we are working on it, and we're hoping to go meet with some political head honchos as soon as we possibly can. But definitely the more people we get signing up, the better. Thank you to all of you that went out of your way to sign up already. Do you recommend PGT after getting only 3 embryos? I don't recommend PGT based on embryo number. I recommend it based on age. Over 38, it's reasonable. Under 38, it definitely is not reasonable. So do not do PGT if you're under 38. It's a total waste of time and money. Replying to Kate Hennessy. Kate, I think Dr. Victory skipped this by accident. I'm not sure what I skipped. Some of them on this new software are hiding messages from us. So I'm not sure why, but maybe I can go back. Let's see if there's one from the lady that just said she missed her question. Oh, last question. In one of your previous Fact or Fictions, you talked about how using a trigger shot alongside your natural LH surge is best practice. All of my IUIs so far have had my trigger shot come before my at-home LH test strip surge indicators. Is there a better way to sync this up together with scheduled IUIs? Many thanks. So what we're telling our patients now, more recently, is that if you are naturally surging, so it's just your natural egg production, or if you're taking Clomid or Letrozole, you wait for your natural surge, and when you get that natural surge, you trigger. If you're being monitored for your cycle with, for example, ultrasounds and blood work, and they're triggering you at a specific time based on your egg size, that's actually wrong. It shouldn't be done that way, so we don't recommend that. And we don't normally do that unless you've had a history of not being able to tell when you're triggering or not triggering regularly on your own. So there are some people where we have to mix and match, but generally speaking, we're aiming for Letrozole, Clomid, and your natural egg production to just have your own natural surge and then add in the trigger shot. And if it's injectable medications or you're irregular for whatever reason or not responsive, then we definitely add in the trigger when we think you need it to happen, or when we think we need it to happen, rather than when your body's going to do it naturally, because sometimes it won't do it naturally. Okay, I just realized I missed having my question. Jess, you have lots of questions. If you have low ovarian reserve at 36 and AMH of 7.51, how long do I have left to ovulate? Oh, with an AMH of 7.51 at 36, years. Probably, I would guess somewhere around 3 to 4 years, unless something's going wrong, if not longer, maybe even more. Morgan, after receiving the response about the question she asked earlier, says, well, crap, what's the name of the study that I can send her so she'll prescribe the Clomid? Could I just call my PCP about this? Seems like the RE is unwilling to do without the ultrasound. It's actually ridiculous for someone to insist that they need to do ultrasounds for Clomid cycle. In Canada, tons of family docs prescribe Clomid, so they should be able to in the US. I don't think it would be a problem. Keep in mind, Clomid is no longer available, so you would have to get it custom compounded, but yeah, it shouldn't be a problem, and you can definitely get that done. That's not a problem. She insisted today. It's very frustrating. Morgan, I'm sorry. Switch REs. Find a different one. I mean, that's super frustrating, and I don't know what they're talking about. But it's totally not necessary. And you can show them the video we did. Just have them refer to that and look at the video we did. I think it was 2 weeks ago, showing that there's no benefit to monitoring whatsoever. So it's there for them to see. I think we might be near the end of our questions. What is the difference between Clomid and Letrozole, and why would you prescribe one over the other? Okay, that's a really good question. So Clomid is a drug that helps you make eggs, and so is Letrozole. And the difference is in their mechanism of action. So first of all, Clomid actually tends to make you make sort of 2 to 3 eggs, whereas Letrozole typically makes you make 1, sometimes 2. But in a head-to-head comparison done in the New England Journal of Medicine, I forget the year, I want to say 2006, but it may have been more recent than that, by an author named Legro, Legro. They compared 6 months of Clomid to 6 months of Letrozole. And in the group that did Letrozole, they had a 27.5% live birth rate. And in the group that did Clomid, they had a 19.1% live birth rate. So 6 months of Letrozole is actually better than 6 months of Clomid. So we typically, in our PCO population, will start with Letrozole. And then if for any reason it doesn't work, we'll go back to Clomid. But we start with the Letrozole because of that study. It has now replaced Clomid and become the first-line agent. If I'm over 40, is it better idea to retrieve egg once they reach size of 18 versus larger? Yeah, so the older you are, there is this theory that you shouldn't wait as long, but everybody should be getting triggered when their eggs are between 18 to 20. There are a lot of centers that wait till the eggs are 20, 21, 22. We kind of reviewed this in last week's Fertility Fact or Fiction. If you are waiting longer and you're going past 11 days, your fertility success rates decline. So definitely when you're older, we're aiming for like 17, 18, even the women with low ovarian reserve, definitely by the time they're getting 18s, 19s, you need to trigger or those eggs will not be as good quality. So that's really important for you. I think we're done. We out-questioned everybody. Wow. Okay, awesome. No glitches this time, guys. I love the new support system. Thank you to Restream.io and to Tarek Ibrahim of Ibrahim Strategies Group. Amazing work, team. I love you guys. Good job. So we will be back again next week with another show. I'm always looking for topics. So if there's something you guys want us to do, you can throw up your comments, questions on YouTube at Dr. Victory or Victory Reproductive Care. Facebook, we have Victory Reproductive Care again. On Instagram, it's rahivictory.md, and Twitter is Dr. Rahi Victory, I think, although I'm very rarely on Twitter. Lots of likes and shout outs for all the questions and the questioners. Appreciate your coming on and being open and putting your questions out there for us to answer and share with everybody. Amazing. And we look forward to your answers. Wait 1 second, because Dr. Jennifer Strong just answered me. I missed the first half of the question, but yes, SIBO can exacerbate endo. Less nutrient absorption will worsen your endo. Jen, I think they're wondering the other way around. I think they're trying to figure out if the endo is, okay, so Jennifer Strong was just answering whether or not SIBO is worsened by endo. But I think what they want to know, Jen, is endo worsening SIBO? But Dr. Strong says that if you have endometriosis, it will make your SIBO worse. I don't know if the question, I think, was asked the other way around, but there you go. And one of our patients says endo causes SIBO issues. Oh, wait 1 second, pause, Jennifer's back again. Yeah, okay, so there you go. So Dr. Strong is answering again. Sorry to black out real quickly there. She does say that endo actually makes the SIBO worse and that the SIBO makes the endo worse. So there you go. All right, guys, I am going to wind it down. Thank you again for another amazing opportunity to help you guys out. Always looking for topics. So if there's something you guys want to know about, don't hesitate. Let us know. Share with us. And again, on our YouTube channel, which we also want to really grow, like, comment, share. Hugely important for us. And we'll see you all next week. Stay safe and look forward to having you up again next week. Take care. Bye.